Now on doing a tuning fork test, the patient will have features of conductive hearing loss. So the RINI will be negative, right? It will be negative, and on doing Weber it will be lateralized to the same side, and ABC will be normal, and Schwabach test will show lengthening. Okay, Schwabach test will be seen as lengthened. Okay, so these are the various things you get while doing a tuning fork test. And of course, when you do an impedance audiometry, I told you, you get a type B tympanogram, and on doing septal reflex test, it will be seen that it might be absent, because it will require at least 70 decibel sound for the patient to have the septal reflex elicited. And if the patient is given 70 decibel in case of a conductive hearing loss of about 40 decibel, he won't be able to get that reflex. Only if you are increasing the intensity of the sound up to about 130 decibel or something, 110 decibel, okay, or 120 decibel, only then the patient will be able to hear the sound as in to cause a septal reflex. Okay, so septal reflex test when done may be absent. Okay, so these are the tests which we do to diagnose a case of auditory media effusion, but it is a clinical diagnosis, and many times you will be able to see a blue drum. Okay, if the secretions within have transformed into glue, it might even appear blue. Okay, blue drum can be seen, and the blue drum is not just associated with otitis media with effusion. It can also be seen in cholesterol granuloma. Cholesterol granuloma can occur due to translation of cholesterol crystals in chronic otitis media, and this cholesterol granuloma can also result in a blue tympanic membrane. Okay, and where else will you see a blue TM? It is seen when there is a history of trauma. Okay, when there is a history of trauma, there could be a hemotympanum, and that can result in a blue TM. Okay, hemotympanum. Now, what kind of trauma results in hemotympanum? What did I tell you? Now, occipital trauma results in hemotympanum because of the temporal bone fracture being transverse. Okay, it will be directly injuring the middle ossicles, but won't be injuring the tympanic membrane. So there will be hemotympanum. Okay, so this is the typical appearance of a cholesterol granuloma, and it can occur along with a case of otitis media with effusion as well. Okay, this appearance is usually associated with a cholesterol granuloma, but the DDF blue TM includes blue ear as well as a hemotympanum. Okay, now I told you to treat the otitis media with effusion, you need a ventilation tube. Now, what are the types of ventilation tube available? It could be a short term ventilation tube, or a medium term, or a long term ventilation tube. Now, what are these short term ventilation tubes? These tubes will be staying only for less than 6 months. Okay, and after that it will get extruded on its own, and it is used for otitis media with effusion. Now, when there is a chronic ear disease, as in a retraction which is seen of stage 3 or 4, you will need to have a ventilation for longer duration. Okay, in that case you will use the other ventilation tube where it stays for 6 months to 2 years. This is a Schaas tube, and here it is a Donaldson's tube is used. Okay, Donaldson's tube. Schaas or Armstrong's tube is also used for this purpose, and if for more than 2 years it is needed, you will need to use a T tube. Okay, T tube is used when for more than 2 years it is needed. Okay, so these are the various types of tubes, and short term tubes you can also use a Shepherd's tube. Okay, Shepherd's tube is also another short term tube. Now, will you straight away go for a myringotomy and putting a ventilation tube in case of a child who presents with chronic adenoiditis and having a notitis media with effusion? No. First of all, we will try to resolve the chronic adenoiditis. For that, we will be giving a steroid spray. Steroid spray is given for long duration, and along with that, antihistamines and decongestants will be given. And even after that, if it is not resolving, for 3 months we will be using a steroid spray. And even after that, if there is no resolution of the otitis media with effusion, you will have to go for a myringotomy and grommet insertion along with the adenodectomy. Adenodectomy is the mainstay of treatment. Along with that, you will be doing this myringotomy with grommet insertion. Okay. Now, what are the types of myringotomy that are done? For grommet insertion, it is always a radial incision that is being put like this. Okay. The curvilinear incision is put in case of acute otitis media to resolve the pulse out. Okay. In case of complications or in case of the acute otitis media is not responding to antibiotics, in that case you will need to put an incision in the posterior inferior quadrant which is curvilinear, because it should not be closing soon. That is why a curvilinear incision is put. Whereas in case of this serous otitis media, you will be putting an incision which needs to close. By after putting a ventilation tube, it has to close, so that we are putting a radial incision. And if it is not opening and the pus is not coming, as in a it's not pus, it is the fluid is not coming. If the fluid has thickened and formed a glue ear, in that case of glue ear, what will you do? In glue ear, you will put another incision in the anterosuperior quadrant like this. Okay, that is what is called as the Bjerkan technique. And when you put an incision like that, what is happening is that air will enter the middle ear in out through that second incision, and this air will push out the fluid within the middle ear. Okay, and that is what is happening in the Bjerkan technique. Okay, Bjerkan technique. So this is another technique for removal of the fluid from the middle ear in case of otitis media with effusion. Okay, now there is another condition which is occurring due to the UCC2 dysfunction that you have to know about. What is that? That is otitic barotrauma. Okay, what is happening in otitic barotrauma? When you are diving or when you go scuba diving, as seen like this, what is happening? The pressure is increasing suddenly, right? Even during air travel, when you are going down suddenly, there is an increase in pressure. Okay, so when there is an increase in pressure suddenly, what will happen? If this is the, yes, you have the oval window here, you have the round window here. Okay, so what happens is that suddenly there is a positive build-up of pressure when you go down in the perilymph as well as in the external ear, and in the middle ear there will be a negative pressure developing, because the pressure, when it exceeds more than 90 millimeters of mercury, there is a phenomenon that happens. The nasopharyngeal tissue will get sucked in, and that results in, what will happen? It will result in locking of eustachian tube. Okay, it can result in a locking of eustachian tube. Okay, so if locking of eustachian tube occurs, what happens is that when there is an increase in pressure when you are going down, what is going to happen? There is a negative pressure here, and because of that the ear ossicles will get disrupted, and because of the positive pressure the round window membrane will rupture, and because of the rupture of the round window membrane there could be a perilymphatic fistula, and even the tympanic membrane also will rupture due to the pressure changes. It will get retracted and finally rupture. Okay, all these things can happen. The opposite can also occur, that is during ascent. That happens only when the patient is having some problem with the eustachian tube, as in case of a sinusitis or when you are having nasopharyngitis. Okay, and there is a eustachian dysfunction. Otherwise, in case of the ascent, what is happening? It is the pressure that is coming down, not increasing. Okay, pressure is coming down, so the opposite thing should be happening, right? So what will happen in that case? The negative pressure will be seen here. Here it will be positive pressure, and when the positive pressure develops, slowly the eustachian tube opens and the pressure will be relieved. Okay, and if there is a eustachian dysfunction, this won't happen, and because of the positive pressure building up, the ossicular rupture can occur, and the perilymphatic fistula due to round membrane rupturing can occur. All those things can occur, and the tympanic membrane also can rupture, and perilymphatic fistula also can occur. Okay, that can also happen in the ascent of flight, especially if you are having a eustachian tube dysfunction. To prevent that, it is recommended that you do not sleep while going for ascent or descent for the proper functioning of eustachian tube, and you have to chew while ascending or descending. Okay, you might have seen a hostess giving you something to chew, right? Yes, the reason behind is this. Okay, and you can give a nasal or oral decongestant, especially if you are having an upper respiratory tract infection. Okay, so these are the things that you have to remember in case of the dysfunctioning of eustachian tube, the otitic barotrauma, the retraction of tympanic membrane pars tensa. All these things we have learned now. Now we learned that due to the negative mid-layer pressure, later on transudation can occur, and that can result in serous otitis media, right? So here you have the eustachian tube. Okay, so when negative mid-layer pressure develops, what happens? There will be fluid here, and that is what is called as otitis media with effusion, right? So if instead of this happening, if there is a blockage as well as an infection coming from the nasopharynx, okay, that infection is causing the blockage because of nasopharyngitis and edema, the eustachian tube is getting blocked. Okay, and this infection is ascending upwards into the mid-layer. In that case, what will happen? In that case, the whole of mid-layer initially will get hyperemic and congested. Okay, instead of this, instead of fluid, what will be happening there? You will have an hyperemia of the mid-layer cleft. Okay, hyperemia of the mid-layer cleft happens first, and that is because of the congestion taking place. You might have seen when your friend is having a pharyngitis, it will appear red. Okay, so similarly it will initially appear red. The whole of the tympanic membrane appears red and congested. Okay, the first stage is the stage of tubal occlusion, and that is followed by stage of pre-suppuration when there is hyperemia occurring. Okay, hyperemia will occur. First, you have the stage of tubal occlusion, then you have the stage of pre-suppuration where you have hyperemia occurring, and then you have stage of suppuration. In stage of suppuration, what happens is that the whole of mid-layer is getting filled with pus. Okay, there will be exudates formed within during the pre-suppuration itself, and later it will get converted completely into pus, and then what happens is stage of resolution or stage of complications. Okay, how does the resolution occur? The tympanic membrane bulges and finally the pus comes out. Okay, the pus comes out to cause a stage of resolution. Okay, so resolution may occur or it could lead to complications. Okay, so how will you diagnose a case of acute otitis media? The team will be red and congested like this. Okay, and initially in the stage of pre-suppuration or hyperemia, there will be a peculiar appearance, what is called a cartwheel appearance. Why? Because the radial blood supply that is occurring. Okay, you have the blood vessels arranged in a radial manner like this. Okay, so it appears like the spokes of a cart, and that is why it's called a cartwheel appearance. And later on the pus can come out, it can bulge and finally come out, and it comes out in a pulsatile manner, and that is what is called a lighthouse sign, similar to lighthouse. Okay, the pus will be coming out in a pulsatile manner. Okay, and it will be mucoid in nature. Okay, the pus will be mucoid in nature. Why? Because mid layer is having a lot of goblet cells. It is most commonly caused by Streptococcus pneumoniae or pneumococcus. Pneumococcus has got the typical appearance of carom board. Okay, carom board appearance is seen with Streptococcus pneumoniae or pneumococcus. And what else can cause? This is a pneumococcus, and it could also be caused by beta hemolytic streptococci. Okay, these are the various organisms that results in acute otitis media. Even Moraxella catarrhalis is another common organism that can result in the acute otitis media. And how will you treat a case of acute otitis media? When a patient comes with acute otitis media, it could be an infant who is having history of breastfeeding in supine position and will present with incessant cry. Okay, or an adult having a severe earache following a common cold. All these are suggestive of acute otitis media. And on examination there will be congested tympanic membrane, and you can confirm that there is fluid within the midlayer, which is pus, by doing a tympanometry, but that is not at all necessary. It is a clinical diagnosis. By just looking at the tympanic membrane, we will be able to see that it is acute otitis media. And coming to the treatment part, I said it is most commonly caused by the pneumococcus, beta hemolytic streptococcus, all such organisms, not the gram-negative organisms. Okay, Haemophilus influenzae. These are the organisms that result in acute otitis media. So the antibiotic coverage should be directed against it. So most commonly what you give is amoxicillin plus clavulinate combination is given, or high dose amoxicillin can also be given. Okay, and this is given as 625 mg TDS into 1 week, and then you will give something for the relieving of the edema. Okay, for that what you do is you will give decongestants. Okay, oral as well as nasal decongestants are given, and antihistamines are also given. And for the pain you give paracetamol. Okay, paracetamol is given for the pain. Okay, so this is how you treat a case of acute otitis media. And if the patient is going for complications and if it is unresolved with a treatment with antibiotic, then you will have to go for myringotomy. A curvilinear incision is put, and where is it put? It is seen in the postero-inferior quadrant. Okay, it is put in the postero-inferior quadrant. Okay, and this incision will resolve the pus within the mid-layer. Okay, now what is this condition that you see here? Is it acute otitis media? You can see it is red and congested and there is bulging of tympanic membrane. But if you look carefully, the congestion is confined to one area and the bulging is in the another area, and this bulge is actually a vesicle, and this is what is called meningitis bullosa or bullous meningitis. Okay, now bullous meningitis, how will you treat this condition? You will have to treat just like a patient who presents with acute otitis media, and sometimes there will be otitis externa along with this bullous meningitis. And what is the causative organism for this? It is said to be caused by Streptococcus pneumoniae, and also influenza virus is said to cause it along with Mycoplasma pneumoniae. These are the various organisms that are implicated in causing bullous meningitis, and sometimes you will need to do an topical eardrops will be needed for this condition to relieve the edema as well as a topical antibiotic effect. Okay, Ciplox D eardrops can be given, and along with that antibiotic against the Streptococcus pneumoniae can be given, that is amoxicillin clavulanate combination can be given. Okay, now there is another condition which is very devastating to the patient when the patient is having an infection with influenza virus. Okay, and what is that? Yes, this condition when a patient is debilitated with a measles or influenza virus, there is a secondary attack by beta hemolytic streptococci, and that can result in a condition called acute necrotizing otitis media. Acute necrotizing otitis media, ACON. Okay, ANOM. Okay, and this condition, acute necrotitis otitis media, is characterized by a perforation which is marginal. And what do you mean by marginal perforation? Even the tympanic annulus will be involved. Okay, tympanic annulus will be involved, and there will be ossicular erosion, and complications like facial palsy can occur easily in case of acute necrotizing otitis media. Okay, so since it is causing a marginal perforation, a secondary cholesteatoma can also occur easily in this condition. Okay, so this is the importance of knowing the condition acute necrotizing otitis media. If there has been a history of measles in a child who is having a foul smelling ear discharge, okay, then you have to suspect a case of acute necrotizing otitis media followed by a secondary cholesteatoma. Okay, so this is another condition which is affecting the middle ear. And now if due to a trauma there is a perforation like this, okay, do you need to give a near drops or something like antibiotics for that patient? No. Traumatic perforation, the best line of management is to keep the ear dry, especially when there is no signs of infection. You have to keep ear dry and give some analgesics. Okay, never put anything in the ear, because if you are putting something in the ear, the sterile environment of the middle ear will be disrupted, because the things from the external ear will get in through the perforation. Okay, here the perforation has occurred from outside. Okay, so it won't cause any problem unless it gets infected. So the aim is to prevent any infection in the middle ear, and then it will heal by itself. Okay, and how does the healed TM looks? Healed TM will heal only in 2 layers. There won't be any fibrous layer. Okay, unlike a meringoplasty where there is healing in 3 layers, here there will be only 2 layers available. Okay, and so it will appear like this. That is, this is a healed TM, and this area will be hypermobile. Hypermobile. When you do a Valsalva maneuver or a serialization, that area will be hypermobile because it is having only 2 layers. Okay, and what else can happen on healing? You can see that there are some white patches seen here, right? Here also you can see some white patches. What are they? These are the tympanosclerotic patches which are typically seen on healing. Okay, these tympanosclerotic patches can cause the ossicles to get fixed. Okay, so if the tympanosclerosis is causing ossicular fixation, you will have to go for a tympanoplasty. Okay, and whenever there is a meringoplasty or tympanoplasty being done, you have to remove the tympanosclerotic plaques as well. Okay, because that area won't be vibrating properly. And why is it occurring? Because in the fibrous area, the fibrous layer of the tympanic membrane is having calcium deposition, okay, and that is resulting in tympanosclerosis due to calcium deposition and hyalinization. Okay, and this is occurring in the fibrous layer of the tympanic membrane. Okay, so that's what happened when there is healing of the tympanic membrane. Okay, and if the tympanic membrane does not heal by more than 3 months, then you will have to treat it as a chronic otitis media, and you will have to go for how you treat a case of chronic otitis media. The condition chronic otitis media and how you treat it will be dealt with in detail in the next session. Okay, so for now let's revise the things that we have already learned today. We have learned about the importance of eustachian tube and how to assess the eustachian tube functions. Okay, then we learned about the eustachian tube dysfunction due to petalous eustachian tube and how to treat it. And what else did we learn? We learned about barotrauma. Okay, so otitic barotrauma is the condition where perilymph fistula occurs secondary to the barotrauma. Okay, perilymph fistula is seen secondary to the barotrauma. Okay, and what else did we learn today? We learned about otitis media with effusion, which is seen chronically. If it is occurring for more than 3 months, then you will have to go for surgery. And in unilateral case in adults, you have to look for nasopharyngeal malignancy. Bilateral in children, most commonly it is due to adenoids. Okay, then we learned about acute otitis media and acute necrotitis and otitis media. Okay, and also about traumatic perforation and how healing occurs in 2 layers, that is the epidermal layer is meeting with the mucosal layer, but there is no fibrous layer. Okay, that is what is happening during healing, and if that doesn't occur properly, tympanosclerosis also can occur where there is calcium deposition within the fibrous layer. Okay, so these are the things that we have learned today. We will be learning about chronic otitis media and its types in the next class. For now, goodbye.